Thank you very much. So, why is this topic relevant? There are a few points I want to share that might, if you're not a mental health practitioner, you might have not been aware of, is that there is disproportionately high levels of tobacco dependence in patients with mental illness. And smoking is the single largest contributor of reduced life expectancy among patients with mental illness. Despite all the other things that we look into, suicide and all that, but smoking remains the single largest contributor. And there are many misconceptions, even among us mental health practitioners, and I'm guilty of some of them in the past. And there is a high comorbidity as well as many of them benefits from specific interventions. Okay, if you look, these are statistics from the United States. In the United States, over the last 20-30 years, we see the prevalence of smoking coming down over the years. It was initially 40+%, and over the years it has come down. This is in the year 2017, but I think now we are looking at somewhere around 16% in the United States. However, sadly, the smoking prevalence rate among patients with mental illness has remained disproportionately high. It was 40+, and at best now we are dealing with 33.3%. So it's still very high compared to the general population. And in patients with serious mental illness, such as schizophrenia and bipolar, the smoking rate is super high. We're looking at up to 85%, and patients with other substance use disorder like alcohol, methamphetamine, cannabis, it can go up to 98%. And the tobacco companies in the past has specifically targeted this group of patients. As you can see, 40% of the cigarettes sold in the United States are sold to someone with mental illness. Such a sad truth. Despite their levels are somewhere around 33, but that means they smoke more than the general population out there. Let's look at our local data. Sadly, we do not have much. We see locally as well, levels are not very far away than the levels in the United States. However, we too see a disproportionately higher prevalence among patients with depression and anxiety in our country as well. And we are moving downwards. And in 2025, our target was supposed to be 15%. But are we bringing along our most vulnerable group together? That's something that I'd like to leave that with you to ask. Are we also doing the same? A society is usually judged on how they treat their most vulnerable group. And patients with mental illness are in our vulnerable group. So sadly, we are not bringing them down together with how we are bringing down with the adult population. Sorry. And there is a bidirectional loop among correlation between mental illness and tobacco use. Mental illness itself is a risk factor for you to use tobacco because many people use it to basically self-medicate. Where else, tobacco use is a risk factor for you to develop mental illness. So it's a bidirectional loop, and the tobacco industry knew this information very, very long before research was done among our scientific community. Because our community, our scientific community, sadly, many times the research excludes patients with mental illness. Many of the research carried out always exclude the most vulnerable group. Tobacco industry knew this, and they targeted and they campaigned specifically. If you see certain tobacco companies, you can Google it for yourself, I'm not going to mention names. They specifically use things like smoking relieves anxiety. So patients with mental illness that have anxiety use that. Smoking helps with depression. This is their tagline, you know. So that's why this group has been targeted over the years. And like I said, they use it to self-medicate. In schizophrenia, they are lacking dopamine in the prefrontal cortex. Hence, patients with mental illness that actually take tobacco temporarily see an improvement in their mood, their concentration, because it elevates the dopamine level in the prefrontal cortex. But again, that is only short-lived. Same thing with anxiety and depression as well. You do see a temporary elevation of symptoms, but again, it's not sustained. Because what happens is, after the temporary elevation, you get upregulation of nicotine receptors in your brain. You get decreased sensitization. So then, now you're only smoking to relieve the withdrawal symptoms, no longer to improve your symptoms. And long-term risk of neuroinflammation disrupts basically all the neurotransmitters that we know for mental illness. Nicotine addiction disrupts dopamine levels, dysregulates serotonin, dysregulates glutamate, dysregulates your GABA. So it's basically a vicious loop. And some of the medication side effects, patients use tobacco to relieve some of the side effects. Like I said, sometimes it helps elevate that dopamine, which is, sometimes some of the medications decrease that level. Number two, some of the medication effectiveness is reduced because of tobacco. Because tobacco, if you see, it's a very strong inducer of cytochrome P450-1A2. And many of the psychiatric medications are metabolized by cytochrome P450-1A2 enzyme. So it indirectly reduces the level of medications and hence it elevates the side effects. And many patients are boredom, because many of our patients do not actually end up working. They do not have a very colorful or more productive life. So they take tobacco to elevate that dopamine level. It's enjoyable temporarily. And like I said earlier, if you stop smoking, you get withdrawal symptoms. And withdrawal symptoms, as we know, many of them meaning restlessness, anxiety, depression. So they feel taking tobacco elevates their symptoms. Vicious loop. I'm not going to stop because it helps me with my mental illness. And as we have seen, even in that percentage of 40%, there is higher dependence and higher nicotine dependence among patients with mental illness. That means they take more cigarettes than the general population. So if let's say the average among general population is 1 box a day, they maybe take 1.5 pack a day. This, I'm sad to say, is some of the myths that run even in my own fraternity, mental health fraternity. And I'm guilty of some of them as well when I was a junior practicing doctor, junior MO in psychiatry. One is patients, we as clinicians feel patients with mental illness are not motivated to quit. However, evidence does not show that. Actually, 60 to 80% of patients with mental illness are actually motivated to quit. But we think they're not motivated. Number two, smoking helps improve their symptoms. We as mental health practitioners feel that. And later I'll show you something very peculiar with regards to mental health. And we believe that quitting might worsen their mental illness, so we are scared to tell them to quit smoking. Again, perpetuates that. And people with mental illness can't quit smoking. We believe that they have so many other stresses in life. Smoking is something that they can't deal with. But statistics does not show that. The quit rate is up to 25%, which is comparable to general adult population if with effective treatment. So that again remains a myth. And it's a low priority thing in psychiatry. When we used to practice, we used to feel that why focus on smoking? Focus on their psychosis, focus on their depression, focus on their suicide. However, none of that kills more than smoking. smoking is the single largest contributor of decreased life expectancy in people with mental illness. And medications should only be prescribed for people that are motivated to quit. Evidence does not show that. Evidence shows an opt-out approach is much more beneficial. Everybody gets treated. Okay, but we still, up to date, many of us reserve that treatment only for the people that want to quit. Okay, let's see something very peculiar with psychiatric setting. And I'm embarrassed to share this, but thankfully it was not in my era, an era before me. My predecessors last time in psychiatry used to use cigarettes as a positive reinforcement. So if you well behave in the psychiatric ward, we give you cigarettes. If you're participating in occupational therapy activities, we give you cigarettes. And this is not very long ago, this is like 30 years ago. So you can see why there's a higher prevalence there. And many of our patients we never even discuss about quitting with them. Majority does not even get that discussion because we don't think smoking is a problem. So why talk about it? And this was a study done by Professor Junit Prakashka. If you know the trans-theoretical model, Prakashka was the one that came up with the stages of change, right? But this is his daughter-in-law. The daughter-in-law, he didn't do much. Prof. Prakashka, psychologist, didn't do much research for patients with mental illness, but his daughter-in-law does a lot of research with the vulnerable group. And she is the one that published a lot of papers with people with mental illness. So this is over the last decade, or maybe 1.5 decades that we got to know. She saw that there's only one, in a psychiatric inpatient setting, only one person got treated for their smoking or tobacco addiction upon discharge. Again, a very, very low rate. So, what are the evidence-based strategies to combat this issue at hand? Number one, of course, the knowledge gap. We need to address the attitudes of our mental health practitioners or general practitioners as a whole. Because you do see patients with mental illness even in your setting. Despite you might not be treating their mental illness per se, but you are treating their physical health. And you have an opportunity to make a difference as well. So if we do, if we do address the lack of knowledge, we can probably get more people on board. And 80% of practitioners are actually interested to learn about dealing with mental illness and tobacco use disorder. And an integrated model is definitely the best. Sadly, we have started to look into integration model for dual therapy, substance use disorder, or alcohol use disorder with mental illness. But tobacco use, we still isolate and let it go to quit smoking clinic and clinic at time. Why are we still stigmatizing this tobacco use? Yeah? Something to think about. And an out-out approach, like what I said, is definitely the way forward. And of course, our patients probably need an early contact. So that means if they have already set a quit date, we see them earlier. And the duration for treatment is longer. Usually we keep them 6 months or longer on treatment. We don't say when you stop smoking, we take your nicotine replacement therapy or varenicline or bupropion off so early. And a combination of pharmacological counseling and behavior techniques is the way forward. I think not only in mental illness, patients with mental illness. So the medications, I think you are quite familiar with. Varenicline, there was a previous misconception, even with regards to varenicline, regarding the neuropsychiatric manifestation. Right? People were afraid to prescribe varenicline for patients with mental illness or patients in large. Even in some countries, they even withdraw varenicline. However, Eagle's trial, taking into consideration, I think, 18,000 patients that have mental illness as well as no mental illness, in 2016 debunked that myth. Using any of the psychiatric medications for nicotine, using any of this pharmacological treatment for tobacco use disorder does not increase the risk of neuropsychiatric manifestation, does not increase the risk of suicide, does not increase the risk of psychosis. So they are safely able to be used in psychiatric patients. So in view of the interest of time, I will not go into detail of each medication. But again, another thing that we need to look into is the cytochrome P450-182. When they stop smoking, if we don't adjust their medication, they start to develop increase in side effects of the medication. Then they attribute that is because I stopped smoking, I get these side effects. But actually, when they stop smoking, we should start reducing their psychiatric medication. So we should know this so that we can do it hand in hand. Next, there are various psychiatric medications that are metabolized by that enzyme, and hence you can see why they use that to reduce the side effects. So many of our psychiatric medications have that. And of course, the dual, the brief intervention, everyone is recommended to be given brief intervention, motivation interviewing, and this adapted CBT is because maybe our patients need simpler instructions. They probably need something that has more visual aids for their CBT. And they also say do not be too fixated at a quit smoking date. When you run the quit smoking clinic, sometimes we are too fixated getting that date. But they said even a gradual reduction has equal effectiveness. Even you preparing a schedule, only for these few weeks you can quit. And then probably we look into taking back if you want to. Just commit for a few hours a day. That is also an effective strategy. So there's no hard and fast rule. And teaching obviously coping strategies, behavior activation helps with addressing their boredom. So do something else. And smoke-free policies. Now I'm proud to say that all hospitals in Malaysia, psychiatric ward, we practice smoke-free policy. We don't give anybody tobacco in the ward, and we do not even let them bring tobacco in the ward. Okay, and universal NRT. I'm proud to say, in my setting in Hospital Melaka, every smoker that enters the ward gets nicotine replacement therapy. Everyone gets a patch, so that we minimize the withdrawal symptoms, we minimize the agitation. We noted that it's a reduced length of stay if we give universal NRT to our patients. And psychiatric ward admission is very expensive. 1 day of stay in a psychiatric ward, we are not paying, government is paying, patients are not paying, it's $1,500, 1 day of stay in psychiatric ward. So if we can reduce with usage of medication which is not going to cost us $1,500, why not? Okay, with that, my conclusion is disproportionately high. It's a major cause of morbidity and mortality. Patients are willing to treat, treatments are effective, and we should use integration of tobacco cessation in mental illness. With that, thank you very much.